Good evening, everybody. Thank you very much. All right, awesome. So tonight's program is an MS Views and News program. This is our MS Summit 2024. I want to thank our sponsors for today. That's Beatrice, Sandoz, and Novartis. I hope that you could all give them a round of applause and say thank you. All right, tonight we have Patricia Pagnotta. She's currently employed at Neurology Associates, PA, and the MS Center of Greater Orlando in Maitland, Florida. She completed her undergraduate degree at Towson State University in Towson, Maryland. Her graduate degree was completed at University of Maryland and did postgraduate work at University of Central Florida. Tricia is an active member of the MS community, currently the president of the International Organization of IOMSN. No, that was passed already. I know. Come on, you didn't update us. She's a member of the Consortium of the Multiple Sclerosis Centers, and she serves on the Southern Regional Healthcare Provider Council. Okay, that's Tricia. Next, we have Megan Weigel. Dr. Weigel is a nurse practitioner specializing in neurologic care in the Jacksonville Beach, Florida area. She has been a multiple sclerosis certified nurse since 2005 and a nurse practitioner for over 20 years. She's also board certified advanced practice holistic nurse. Dr. Weigel earned her doctor at nursing practice from the University of Florida, where her research emphasis was on preservative healthcare. I'm going to save you all the drama of me not being able to see. It's in those booklets that was given out to each of you, all right? Dr. Samuel Hunter, on the far side, completed both MD and PhD in pharmacology at the University of Texas and neurology and neuroimmunology as a clinician investigator at the Mayo Clinic in Rochester, Minnesota. He has extensive experience in inflammatory diseases like multiple sclerosis and expertise in neuroimaging. No phones. Gosh, where have you been? Yeah, I got it. Okay. All right, great. And for those that don't know, because I didn't say anything to all of you at the very beginning, my name is Stuart Schlossman. I am president and founder of MS Views and News, and I too have multiple sclerosis, and I've made it my journey and my life to be able to provide these educational programs to people all across the United States to make sure that people are learning what they need to know about MS. All right, so this is a special type of thing that we've done in the past where I give the doctors, I'll say, we'll use that term for everybody, I give them each a question. They're going to get the same question, but they have to answer it differently. All right, so they're each going to either get 60 seconds each or 25 seconds each, 20 seconds each, and I will pull the mic from them. You have a mic there. I can't really pull it, but I'm going to shoot you down if you go on rattling and talking too much. All right, we're going to try to get in all the questions. After we get through the questions that we have for them, we will then go around to the audience and ask you if you have any questions to ask that we have not asked, and we're also going to take the questions from the online audience. So the first question, and I'm going to start with Dr. Weigel. How is multiple sclerosis today different than from years ago? And you have 60 seconds each to answer this question differently.
Oh, thank goodness. So different from years ago. I think the biggest thing is not saying, oh, we've got to wait for you to have one more event. Oh, we've got to wait for you to have, another few brain lesions before we can make a diagnosis. With early diagnosis and early treatment with high efficacy therapies, we're really making MS boring, and that is a beautiful thing. I'm done.
Thank you. That was quick. All right. Patricia Pagnotta, take it away.
Well, I agree with Megan totally, but I think what has changed dramatically is the fact that we have become so much more educated, and I appreciate the fact that hematology has helped us so dramatically with understanding some of the immune system. Dr. Hunter may have known a lot of this before I did, but there are a lot of therapies that we have now that we did not have, and so we are able to, for many individuals, slow down this terrible disease.
That's great. Some of us have been around a long time. You're getting to hear from them tonight. You're also getting to hear really good ideas. But in the last 50 years, MS has been demystified. And furthermore, we've learned that if it acts like MS, it's usually MS, and you treat it like MS. and you need to keep treating it like MS. And the studies have accumulated more and more, and one after another, myths about MS have been exposed. Some of the myths are, oh, well, just because you had it doesn't mean you'll keep having it. You always keep having it. Just because you're doing well doesn't mean you need treatment. Yes, it does. You're always almost going to need treatment. There are a very small subset of people who can stop. If you have really bad MS, it'll probably calm down. You don't have to do anything except to keep your lifestyle right. Doesn't fix it. It helps your health, but it doesn't fix it. You need treatment. Treatment's cheaper than it's ever been. Treatment's safer than it's ever been. Treatment is more available than it's ever been. Really just two things lead to MS. Low vitamin D, you can't do anything about it. Tobacco smoke, you can do something about it. And the genes, you can't do nothing about it because they were genes that kept your ancestors alive.
Great, thank you. All right, next one, Trish is first. What are the different types of MS? You have 25 seconds.
So there's the relapsing form of MS, which is usually the most common. 65 to 85% of the time persons are diagnosed with relapsing forms. But relapsing form also includes secondary progressive in people who are mounting disability but still having inflammation that we see through relapses or MRI activity. And then there's primary progressive MS, which is a type of MS that only 10% of individuals have. If you have primary progressive, you did not start as relapsing. You were primary progressive from day one. And what it means is that gradually your disease is getting worse over a period of time. Thankfully, we have disease-modifying therapies for each one of these.
Okay. Dr. Weigel.
Okay, so Tricia said relapsing, remitting, primary progressive. I'll say inactive secondary progressive MS, maybe another type in a person who is not having active relapses or new MRI lesions, and an even less common form of primary progressive MS is primary progressive with relapses, which is a very small subset of people. And if Dr. Hunter can come up with another type, then he gets a prize.
That's right. That's why I gave it to him last.
Well, it depends on how you're going to classify MS by what the clinical presentation is or by how severe it is. And nobody's mentioned the severity yet. So we talk about benign MS, which is the best 5% of people, which after 20 years don't have any major impairments. And we talk about malignant MS, which is the worst 5%, which are usually not walking 5 years into disease. The other characteristics are how it presents on imaging. And the most dramatic form of MS is called tumefactive MS, which means like a tumor. And these are very large lesions. They're often mistaken for tumors. And they can be, just incidentally found, or they can be catastrophes when they occur. And then you have people who have small MS lesions, and just a few of them that are extremely strategic. And these are usually the people who are more like primary progressive MS. If you watch people with any form of progressive MS, they'll still have relapses. They're just less obvious and less frequent.
Thank you. Sticking on this, I'm going to go with you for a little bit more. Can you explain what PIRA is?
Say that again.
PIRA, P-I-R-A.
Well, I need to know what the PIRA is because it's an abbreviation for something I've got another abbreviation.
We'll skip over this for the moment. I'll get back to that a little later on. And can you tell us about exactly?
Well, that's a really progression independence of relapse activity. That's used to be called disability that was progressive and not relapsing. And this is somebody else's new. That's somebody from the military. It sounds like likes to make up new words and acronyms. But basically, one of the myths about MS is people stop having relapses and they just slowly get worse. The reality is almost all new disabilities occur with a very well-defined time scale. They appear. People don't realize they do it, but if you measure people with MS serially to one time after another, you realize it starts at some time. It's not imperceptible, and they remit. So it doesn't really matter how you get there, and most people get there with relapses. But there are people that slowly get worse, and they're usually in lesions that start with relapses. These areas of damage are important areas in your nervous system. They're important disabilities. They're like legs that don't work right. And this is why we measure this. They're almost exclusively in people over 40 years old with MS.
Ding, ding.
Okay.
All right. So, Tricia, I got one for you. Let's talk about NEDA. No evidence of disease activity for those that don't know.
So no evidence of disease activity means that you are clinically stable in every way that we measure. So your MRIs are not changing, you're not having relapses, and you're not having any disability progression. So in essence, your disease is in a controlled remission. And as Dr. Hunter said earlier, that is not a situation where you don't need disease-modifying therapy. It just means that the disease-modifying therapy you're on is working.
Okay, thank you. Dr. Weigel, you want to add anything to that, to either one?
No, I absolutely agree. I think that PIRA as an acronym is something that has evolved in an era of perhaps therapeutics that are trying to figure out how to stop this basically secondary progression that's not really secondary because it starts from the minute the disease occurs, versus stopping relapses. So it's just a way of saying people have disability that's and changes in the brain that are occurring from the minute the disease begins.
Okay, thank you. Continuing with you, Dr. Weigel, what can you tell us about smoldering MS?
So that's sort of as part of the whole PIRA picture. So the theory of smoldering MS is that there is a process that's happening in the brain independent of relapse activity. Uh-oh, I just lost you guys.
We're still here.
Okay. You can hear me?
Yes.
There's a process that's happening independent of relapse activity that's causing disability to happen, whether a person is having new MRI lesions or relapses. And it's part of that secondary progression. And that process may have something to do with cells that are specific to staying in the central nervous system, like microglia, the smoldering MS process. A few other acronyms that people may have heard of are, oh my goodness, paramagnetic rim lesions, chronically active lesions. So it's a process. It's not a new process. It's just that we're able to see it better with more advanced imaging. We're able to try to define it. And that means as we begin to understand it better, that hopefully there will be a therapeutic armamentarium to help stop that disability that keeps happening in people, even folks who are on a highly effective disease-modifying therapy and say have NEDA from the standpoint of no MRI activity or no relapses, but yet, they're getting older and they're getting worse. Part of that process is aging. Part of the thing that really helps some of this smoldering neuroinflammation are significant lifestyle changes. Doing Dr. Gretchen's exercises, making diet changes, reducing your stress, helping your sleep, normal brain health type things. So that's my take on smoldering inflammation.
Thank you for that. Now, switching subjects again, let's talk about the since Dr. Weigel brought up about efficacious medications. So let's talk about that. Dr. Hunter, what do you feel are the most efficacious MS treatments to date, and how do they work?
When you talk about disease-modifying therapy in terms of efficacy, those are drugs that control the severity of the inflammation. We have 3 tiers. We have what we call in the past the frontline tier, the platform tier. Those are the older medicines, the injectable interferons and glutarimer acetate, and a oral drug called teriflunomide or Aubagio. They have about the similar efficacy. We have what we call enhanced efficacy drugs, and there are several classes. There's the fumarates, the S1P modulators, and the low-dose CD20, and a drug that's lightweight chemotherapy called cladribine. And then we have the highly efficacious therapies, which are a couple of chemotherapy drugs we don't use anymore. The king of the treatments called alemtuzumab, which is a very hard drug to use. The heavy lifter now, which is called ocrelizumab, and other CD20s, which are closely related to it, will do similar things. And the older drug, natalizumab, used to be called Tysabri, which is very efficacious but riskier one of the bunch.
Tricia, can you continue with this?
Well, I guess the thing is, when I talk to people about their report card for MS, in addition to the three things I told you about, not having relapses, not having MRI activity, and not having disability, I tell persons the right drug for them is the drug that they can take, the drug that is controlling their disease. I mean, what might be right for one person is not right for another person. So it's a matter, is it keeping you stable, and are you able to take it? So if a drug is prescribed for you to take it every single day and you somehow forget, that's the number one reason for non-adherence with medications is forgetting. If you forget to take that medication, then you can't expect always to get the same efficacy that we saw in clinical trials. So it's very important that you take a medication that you can take and that is keeping you stable. The other thing I just want to comment on is I have a lot of individuals that come into my office and they want the latest and greatest. They may be stable and they may have been stable for a year, 2 years, 3 years, but something new just came out and I know that is better. If you're stable, you're stable. I can't get better than that. Even what we might think is the best drug, the most highly efficacious, that doesn't mean it's going to work for you. If you're on a drug that's working for you and you're tolerating it, that's the best drug.
Awesome. Thank you. And thank you all for your answers so far. Now we're going to go on to something else. And that is, I'm going to start with Dr. Weigel. What are the top 3 questions you think that MS patients should ask when they're in to see you?
Should ask their provider.
25 seconds.
Okay. If I'm taking all of my medicines like I'm supposed to modify my disease and to alleviate my symptoms, what are the 3 best things I can do for my health on my own to discourage my MS from being active and to empower myself? That's question number 1. Question number 2 is, can you give me the name of a good primary care provider so that I can stay up to date on age-appropriate screenings? And then question number 3 is, can I see my MRI?
Thank you. I'm going to need you to remember those questions because I'm going to get back to that after I take the answers from the other 2. So, Dr. Hunter, 25 seconds to answer the same thing.
Very good. Number 1 question. My MS medicine isn't working because I still feel fatigued. Nope, it's working. The benefit is what doesn't happen.
Just ask, what questions should they be asking?
That's okay. Well, I'm going to give the answers too, Stuart.
No, not yet.
The second question is my brain still shrinking? And so we try to address that. And the third one is, do I still have to take treatment?
Great. And Tricia?
So am I stable? And then the next would be, how do I best communicate with you? How do I get a hold of you? When do I need to go to an emergency room or some other urgent care or something? And then the other thing is, what are the potential side effects and what can I do to recognize those of a drug that I'm currently on?
Great. Thank you. And not to get you too confused, but we'll go in the same order. Dr. Weigel, can you tell us what your answers would be to the questions that those patients should be asking you?
Yeah, so for the first question, it would be move your body in any way that works for you. Choose a nutritional plan. I hate the word diet, but choose a nutritional plan that works for you. And believe it or not, all of the MS diets are actually plant-based whole foods diets, even though some of them do allow you to eat animal protein and fish. They are all plant-based diets, so follow a plant-based diet. My second question, what was my second question?
I don't know.
My third one is, can I see my MRI? And the answer is yes. I think that patients who live with
Primary
MS
care.
should, say that, what was that, Tricia?
Primary care doctor.
Thank you. So yes, everyone with MS needs a primary care doctor. Everyone with MS can still get other things that can make their MS worse, like diabetes, hypertension, coronary artery disease, hyperlipidemia, inflammatory bowel disease, lots of other things that can affect their MS. And then the third question is, can I see my MRI? And the answer should be yes. You should be able to review your MRI with your MS provider and understand exactly what MS looks like. Might I add, can you count my lesions? The answer is probably not. And does it matter? The answer is the volume of MS lesions probably matters over time. But like Dr. Hunter mentioned, sometimes a person has a few brain lesions and spinal cord lesions and very, very expensive real estate, and they have more disability than a person who has hundreds more. So, so the count isn't as important as the where, the expense of the real estate. But I do think you should be able to look at what you're dealing with.
Thank you for those answers. And Dr. Hunter, if you
You
remember.
want me to answer my questions? Your brain shrinks slower once you get on treatment. If you get highly effective treatment, it usually goes back to the normal rate of shrinkage. And as far as is your brain shrinking, it's always shrinking. It gets worse when you're over 60. But people with MS, by the time we diagnose it, their brain is usually already smaller than normal. As far as do you need treatment? Well, the evidence is if you've needed more than trivial amounts of treatment for your MS in the last 15 years, you still need treatment for your MS, and the risk of disaster is about the same as flipping a coin. And unlike what the myths often are out there, is that older people don't need MS treatment. Well, no, older people whose doctors think they don't need MS treatment usually need a different doctor.
Thank you, Tricia.
So my first question was how to communicate with your healthcare provider. So one of the things that we enjoy is an electronic medical record. And I say we enjoy it. It's a double-edged sword, but you should enjoy it because it's access to your medical record. And you should do everything you can to be able to get into your portal, however that is, and communicate with your healthcare provider, because that A goes immediately into your chart. B, it's probably the most effective way to communicate, because I don't know of any provider's office who doesn't have a phone system now that almost looks like calling Social Security. So if you want your question answered, if you have something you want to say, I tell my patients, if you've got a bunch of things happening to you, just send it to me in your portal and I'll have that for your next appointment. So that's the number one thing. When should you reach out to your healthcare provider, or when should you go to an urgent care? When you're not feeling well. Now, we tell individuals with MS specifically, if you have something that just happened to you and didn't last for very long, a couple hours, 4 hours, less than 24 hours, it's probably not a relapse, but it might be something that you still need attention for. It could be signs of something else going on. So again, if you send us a message, we can kind of help direct you. But sometimes that means when you send us a message, we're going to need to have you come in. So please be aware, if you're sending your healthcare provider a message, we have an onus to be able to sometimes physically see you and be sure what we're doing. The last was, are you stable? You should be able to ask your healthcare provider as to what are you looking at other than what I tell you as stable. And typically I ask persons things like, well, what did you do last year this time? I usually think about holidays because most people recognize holidays. So last year for Memorial Day, did you host the picnic? Were you doing the cookout? Did you make the hamburgers, hot dogs, the eggs, salad, whatever? Or did somebody else do that for you? And what did you do this year? Things of that nature. The other thing was side effects of medication. So any medication you're on should have a website that you can go to and give you all of the ins and outs of that medication, but your healthcare provider would have described that to you when you went on the medication, but sometimes you hear that and it's a blur. Feel free to look back at that again, because if you're on a highly effective therapy and something happens to you, you want to have that treated emergently.
Thank you. Next. And Megan, we can see you and we can hear you. They're going through some technical stuff on this side. All right. So for
I'm
you,
ignoring that because I can hear you.
gotcha. So for you, 25 seconds, please. We got to try to stay closer to these timelines. What do you feel is the best protocol for people living with MS who struggle with anxiety and depression?
For number one is talking about it with a healthcare provider. Number two is coming up with a plan, and that plan might include counseling. It might include medication. It should probably, at the very least, include counseling. And usually the two together work best. I think also that in finding things that you like to do that make you happy, accessing things like meditation, spirituality, and other tools like breathing exercises, biofeedback can be very helpful for anxiety. Hope you can still hear me.
Yes, we're hearing you. Okay. Tricia.
So obviously we didn't rehearse this. I would have said many of the same things, but hobbies, I mean, it's important to stay active in the things that bring you joy. It's also important to stay active in being social. So be with other individuals, whether they're support groups that you do virtually or in person. Be with family members, have a good support system. And if your healthcare provider, when you share, as Megan said, with your healthcare provider, if they ask you to go see somebody who specializes in that, say yes, because we don't do everything. And that's the importance of having a primary care provider and many other. It's a team that treats MS. So I am not a professional in treating depression. I dabble at it a lot. But when I'm done, I need you to see somebody. And as you know, our previous speaker spoke, is depression is curable. I can't cure MS, but I can help you, if not manage completely, I can help you cure depression.
Thank you. 25 seconds.
Amen. Hallelujah. Say it again, sister. Depression is a fatal disease. Depression is a kind of inflammation in the brain. We didn't realize that till about 10 years ago. And MS is inflammation in your brain, and the most common mental symptoms of MS are so indistinguishable from depression. We use depression scales to measure them. It's very important to feel like yourself. See a psychiatrist who sees you regularly and gets it fixed. They will find something that works. They always do. Don't ask your neurologist to do it. Don't ask your primary care to do it. Don't just see a counselor. See somebody who knows how to make your brain work better.
Dr. Hunter, because you're most close to rural America, I want you to answer the next question. Continuing with what we were just talking about, is there something different you can add for those living in rural America where there seems to be even a lot more depression happening than in urban America?
Well, the good thing about mental health care is the government's decided they'll let you have it by telemedicine, and they'll deny you just about every other kind of health care by telemedicine. So it is good that you've got access to that, and you should take advantage of it. But the things you can always do to help yourself, just like Dr. Weigel said, is good nutrition, good physical activity, and you can teach yourself a lot of skills for improving your mental health. You can get a lot of these off YouTube now. It's amazing the resources that you have, and you can teach yourself. But in rural America, you get out and you get to walk to the barn in the mailbox. Get up and walk to the barn in the mailbox. That's the best exercise you can get. Take a walking stick so you don't fall down and break something.
Great, thank you. Dr. Weigel, can you discuss up-and-coming MRI biomarkers and what that means for diagnosing and monitoring MS progress? Please take no longer than 50 seconds.
I won't, because I'm not quite sure what to even say. Up-and-coming MRI biomarkers.
Okay, leave out leave out MRI and just go with the biomarkers.
Okay. Well, the newest biomarkers that we have are these serum tests, so blood tests, looking at things that may be sensitive for picking up inflammation in the central nervous system that we can measure in the blood. So things like neurofilament light, GFAP, BAF. I don't know the Dr. Hunter probably knows all of those acronyms, but I don't know the words for them. And then when we look at them together, we have a test called the MS disease activity test, which measures 18 biomarkers. And I think it's important to understand with that test that test is validated, but to be sensitive and specific to inflammation in the central nervous system that goes along with MS, but only one of its components is validated on its own. So you can't look at each of those 18 proteins and separate them out from that MS disease activity test. But it is certainly exciting to have something else that you can look at to measure disease activity in MS. And this test specifically is for a new MRI lesion or a relapse within 60 days of having the test done. So not perfect, but an additional piece of information that we have, which is nice to follow. And also people with MS love to know what's going on underneath the surface.
Thank you. Dr. Hunter, what can you tell us the differences between Octave's biomarker and the neurofilament light?
Okay, so the thing that people are calling Octave is called the MS disease activity. It's a measurement of 18 protein values in the serum. Only one of those markers really makes a big difference, and that's neurofilament light chain. You can order up, any doctor can order up neurofilament light chains, knowing what it means, because guess what? When you check people with MS for neurofilament light chain, what is the value? It's usually normal. It's normal 85% of the time. And when it's not normal, you usually have such rip-roaring MS, any doctor would say, well, I'm not surprised your MS is really out of control. So how does it help you? The answer is it doesn't usually. If you get it for free, fine. If you're paying money for it, it's a waste of money. Of the 18 biomarkers that are tested in that panel, the MSDA panel, 5 of them have any significance at all, and one of them is important, and the other 4 kind of, there's a little bit of advantage to 1 or 2. So if you get them cheap, that's great. The best biomarkers, your MRI scan, done appropriately according to what's called CMSC criteria, which happens about 10-20% of the time at most MRI centers. That's really useful. What are called MS functional measurements, which are how fast you think, something called symbol digits modality, which you can find software to do yourself and monitor, time 25-foot walk, and most importantly, the 9-hole peg test, which you can learn to do yourself and keep track of your dexterity.
Okay, Tricia, slightly different for you is how is your office handling these different biomarkers?
So I don't know what labs you have here, but in my area, LabCorp has the neurofilament light, so we can order that from LabCorp, and most of the time the insurance will cover that. Octave has those 18 different proteins, and that is, you have to go to a special lab. It has to be processed differently, and there is no guarantee that your insurance will cover that. Right now, if you have Medicare, it's free. If you have commercial insurance, it could be up to $500. And I tell individuals, well, this is something really nice, another number, but I need to have many numbers in order to make a decision. If somebody's number, it's a scale of 0 to 10. And so somebody's number comes back a little bit higher and they're on a highly efficacious therapy. Did they bump their head or something? I don't know. I need to have a number. It's like taking a thermometer and taking your temperature. Are you always 98.6? Most likely not. So to have a running number to know what you normally are would be the only way to really make decisions off of that a marker as they put all those together and come up with a number. So it's intriguing, but it is not what we can base decisions off of at this moment in time.
Thank you each for each of your answers on that important subject. All right, next, I would like you each, please, to take 30 seconds and tell me how you can discuss how telehealth has impacted access to care for people living with MS in various parts of the country. So I'll start with Dr. Weigel, since she's left to right.
Oh, it's really been a great option for us. We have patients who travel hours to our office, and by the time they get to the office, they're usually late, exhausted, and then have to go home. So telehealth has made a big difference for patients and for us, quite frankly, from the standpoint of being able to be flexible. I think that, we need to see people living with MS more frequently than every 6 months. There's so much, particularly when there's so much going on in the disease and so many symptoms to manage, so much to monitor, that telehealth visits in between in-person visits really help us manage patients safer. And they help meet expectations for both the provider and the patient.
Thank you. Tricia.
So telehealth came out of COVID, and I think that it has its places and it's very good. And yes, it does help us have access to individuals readily in their home. And seeing what your home is like is invaluable to us because otherwise I had to wait for a home health care nurse to call and tell me that, so-and-so has this hazard, that hazard. And did you know that they don't have anybody with them during the day? And so different things that we can actually see by seeing your home. The only thing that, I have as a quote, potential negative about telehealth is that not every visit can be telehealth. I need to put hands on individuals, touch them, examine them. And so, yes, we can go back and forth, but there has to be a balance between what we do from a telehealth perspective versus what we do in regular routine visits. Now, if you're having an emergency and there's something that is simple that we can do, that would be something different. But if you think something new is happening to you, I might really need to be able to see you to assess that.
Yes, it's your turn.
I agree very much with the nurses. The good thing about telehealth, there are some things you can get done. You certainly do paperwork. You certainly can monitor that people are complying with a long-term safety plan. In certain circumstances, a gross neurological exam, just an overall impact in seeing somebody move. With your prior database, you can make some assessments. The bad things, you can't do a careful exam, like Ms. Pagnotta said. That's really important to ascertaining what you need to do with MS. So it can't supplant MS. The second thing is the government won't let us refill controlled substances. And half of the medicines we use, they've devised as controlled substances. Things that will make a rat push a lever are not allowed to be refilled. And this is about half of the medicines that people with MS need treated. And they treat these drugs closer to fentanyl than they do to Tylenol, even though Tylenol is more dangerous. So until your legislature fixes what the CDC screwed up 10 years ago, we can't really use it effectively, even to keep you refilled with medicines that are important to feel right, like sleeping pills or gabapentin, or non-narcotic, non-opiate pain relievers like tramadol that they call opiates. So that's what's wrong, and that's why it doesn't work right now.
Thank you. Last question, and I'm going to need you all to wrap this up real quick so we could get to the other questions from the online audience and anybody here. In seeing so many individuals impacted by MS, what are your recommendations to patients regarding setting goals and priorities in both their personal life and personalizing their treatment plans while living with MS? Briefly, 30 seconds. I'm going to give you.
It's longer than 30 seconds.
Yeah, I guess the briefly is have a plan. Know where you're going, know what you're going to share with your healthcare provider, prepare for visits. So there's MS Views and News has several tools on their website that you can use to prepare for a visit, and then be able to talk about where you're going and be with all of these providers that can help you, physical therapists, nutritionists, the whole occupational therapist, speech therapist, and develop a plan for how you want your life to go, and then act on that plan. So eat well, sleep well, do the things that help us take care of you, and don't do anything harmful to yourself like smoking or drinking or any of those other things.
Dr. Weigel, you next.
So I'll say two things. One is that in integrative medicine, we say healing is possible even when a cure is not. And the second thing that I would say is that you are your healer. Your healthcare provider can't fix you. So within that realm of goal setting, it's really important to set goals that empower you to make changes that will affect your disease, that will affect your brain health. Your healthcare provider can help you choose the right disease modifying therapy, can help you tease out your symptoms, can help you figure out what a relapse is. But you have to decide the lifestyle changes that you're going to make that will empower you so that you can live a life that leaves you feeling well in spite of having MS.
Thank you. Another long-winded guy. Go ahead.
Was that permission? No tobacco. Treat your waistline. Eat right. Exercise. Those are things you have to do for yourself. Get your sleep right if it's not right. You have to take disease-modifying therapy if you want access to drugs, which really make a difference. You gotta follow some rules. You gotta get in there and do it with drugs that may not be the best, but if you don't start doing it when you really need help, they'll deny you access to highly effective treatment. And this is a long-term game. As one of my senior colleagues said, MS is a marathon, not a sprint. You got to settle in for the long haul. The benefit of everything you do is what doesn't happen. And if you don't do it, bad things happen.
Well, thank you to all three of you. And I hope that everybody that attended and watched online appreciated it as well. Now, we do have questions that came in online, so I'm going to go over there and get them. And for anybody in the audience that's here has any questions, Jennifer's going to go around with a microphone and take your questions as well. So do you want to go up and see if there's anybody that has a question? And I'm just going to get down and see. This is why I need a doctor. Anybody out here have a question? All right, she'll be to you in a minute. Grab a microphone. Is it on? It's not on. All right, I'm going to take one. While we get that microphone figured out, I'm going to take one from over here that's online first. Is 65 too late to start a DMT if you're in SMPS? It's probably just SPS. Megan, you want to take that one?
So, I mean, is the question.
So basically, she or he is asking, is 65 too late to start a DMT if you are secondary progressive?
I understand. So if a person has active secondary progressive MS, which means that person, has been bopping along with probably some neurological stuff that was either misdiagnosed or ignored, and then eventually they get to the right place and they're found to have an MRI that has enhancing lesions, or maybe they have a relapse, but they've had disability progression. If a person has secondary progressive MS that is active, then 65 is not too late to start a disease-modifying therapy. Our disease-modifying therapies are FDA approved to treat active relapsing forms of multiple sclerosis, which includes secondary progressive.
Anybody else have any answers to that?
Yeah, I will make a comment that how people define active MS is often not based on reality. And the reality is, if you're over 50, if you have an enhancing lesion, people usually fall out of their chair because it doesn't happen in older people. You have active disease if you've got new lesions that weren't there before, or enlarged lesions, or you've had a relapse or an objective change in disability over a short term. That's active MS. And as far as we define it, everybody who has, for practical purposes, secondary progressive MS has active secondary progressive MS. And that's how the definition was defined. And that's how the government defined it for treatment. So if you're getting worse and you got MS, you need treatment, regardless of whether you're 16, 45, 25 years later, and you still are having new problems, or you're 80 years old. Now, can some people stop? Some people can stop. After 10 years, nothing's happening. Absolutely nothing's happening. But most of the time when people want to stop, somebody told them to stop because they shouldn't need treatment, and that's a myth.
Okay, thank you. There are a lot of online questions, so instead of me going back and forth and asking for 3 different answers, I'm just going to look at the question and ask one answer from each of the doctors that we have. Okay, so the first one I'm going to ask Tricia Pagnotta, please, is what is the treatment for progressive MS?
The only treatment we have FDA approved is ocrelizumab.
Okay, is there a question out here?
I have a question here.
Thank you, Dr. Hunter, for answering about old people. I have been told that I need to stop because I'm old. I don't have relapses, but I am progressing slowly, and the medicine that I've been taking is working. And as soon as I slow it down or stop it for any reason, I get worse. So keep on going, right?
There are nice things to say to doctors, but I can't think of them right offhand. Ugly things come to mind. But there's always a need for an assessment. And the paper that I just got published about this last month was the decision should always be between the risks and the benefits of the treatment. And doctors who really, really, really want you to stop, generally it's because they don't want to do the paperwork.
Thank you.
Do the other ladies agree with all this too?
I ask my patients, what do you have that you want to get to lose? So 65 is not old, 75 is not old anymore. And if you're not blind, what would it be like to be blind? You could have an optic neuritis and go blind. So if you're not willing to lose something and you still are actively getting worse, then you deserve a disease modifying therapy.
Okay, thank you. Next question, Dr. Weigel. If a person is diagnosed in their 40s and known to have had MS from an earlier stage but was never diagnosed, will they progress faster than a person who was diagnosed shortly after they started having symptoms?
Dr. Hunter wants to answer that.
I see that.
I think, like, is the question really that, like, they had MS for a long time and they didn't get diagnosed till they're 40, and will they progress faster?
That's the question.
Okay, so early diagnosis and early treatment results in less disability. That's the bottom line. It doesn't matter how old you are. Also, reaching an EDSS score of 6 results in a steeper slope of disability acquisition. So the sooner that you're diagnosed, the better off you are. And it doesn't have anything to do with age so much. You can be perfectly healthy until you're 40, or you can have started to have symptoms of MS when you're 16. I hope I answered that right. Early diagnosis and treatment is very important.
But it's spilled milk. If you didn't get diagnosed until you're 40 and you think you had symptoms at 20, it's spilled milk. You can't do anything about that.
Yeah,
You just start from 40 and you move on. And we as healthcare providers will try to provide you with the treatment that will help you be the most stable we can from that point on.
Okay, thank you.
I think it's worth noting, and I actually learned this from Dr. Hunter, that there are insurance claims for certain symptoms many years before people are diagnosed with MS, particularly chronic fatigue. And that is such a, it's not a hard symptom. And so like Tricia said, we can't go back and cry over spilt milk. Like, oh, for 10 years I was tired before I had a brain lesion, or something like that. What we can do is treat you the best we can at the time of diagnosis.
People who are diagnosed in their 20s usually get disabled in their 40s, and people who are diagnosed in their 40s usually are disabled when they're diagnosed.
Okay, thank you. Jennifer, you have any questions there?
Any questions over here?
Okay, back to online. Oh, we have one here.
I have 2 questions. First one, Dr. Hunter, you talked about malignant MS and you said that it was usually measured by not walking. Can it also be cognitive decline that you would consider malignant MS?
Sure, it can. It's just not mild cognitive decline is so common in MS. It's the most common reason people don't work. If you have somebody who's demented, that would be like malignant MS. It's something you don't expect to happen in people with MS at a short latency of disease activity.
Thank you. Second question is, you talked about, or everybody talked about progression. Can progression be related to the decrease in your residual reserve?
That's a nice way for talking about swimming pools, but that's not how the nervous system really works. Information either moves or it doesn't move. That's called, the communication. It can either be because the conduction is there to a certain point and can't make it across. That's called conduction block. Or it can be the wires are gone, which is called axonal loss. And you really can't tell the difference observing people. When we see people who are disabled, they get a course of steroids and wow, what a difference for 3 weeks. We know it's conduction block. When we see people get dalfampridine, which is the drug that improves conduction block, and they get better, wow, there's still something there. When we see the MS get controlled and people miraculously improve in disability over a couple years, like they do on highly effective treatments, we go, wow, we didn't know how much they could get better. That's repair. That's repair of the axon, remyelination, resolution of inflammation. That's how you get rid of conduction block. It's very hard to tell the difference between conduction block and axonal loss. When we look at spinal cords and they look wrecked, they probably have mostly axonal loss. But you never know until you try and you treat somebody.
Thank you. All right. Patricia, can you please define what is mild MS?
So mild MS is a person who has had MS for 10, 20 years on a disease-modifying therapy. and is not progressing. And so many providers in olden days, when I was coming up, well, if you're not progressing and you don't have very many symptoms, maybe it might be that you walk just normal and somebody says, but you don't look like you have MS. You might have symptoms on the inside that people don't feel. But back before we had as many disease modifying therapies as we had now, people would say, well, you have mild MS, benign MS, you don't need to be treated anymore. But we find that those individuals, mild MS is really things that are less visible, less disruptive to your life, but they're still there and they still can get worse.
Thank you. Megan, Dr. Weigel, rather, can you please tell us if it's safe to have a baby with MS?
Please have a baby with MS. I mean, please have MS and have a baby. So you got so
That sounded good.
pregnancy is protective from an MS standpoint. There are certain autoimmune and inflammatory diseases where pregnancy isn't protective, and in MS, it's very protective to the nervous system. It actually is, somewhat of a disease-modifying therapy. Being pregnant is the best prognostic factors for your MS after pregnancy are having been on a disease-modifying therapy before getting pregnant. And having your MS controlled on that disease-modifying therapy before you get pregnant. So many people want to say, well, I want to wait until, we're going to try to get pregnant and I want to wait to start something. And that is usually a recipe for disaster, because what happens is people end up having a major relapse and it puts off their attempts at pregnancy. So when I started 25 years ago, doctors were saying that you probably shouldn't get pregnant if you have MS, because what if you can't take care of the baby and all these horrible things? And there are women my age, I'm in my late 40s, there are women my age who were diagnosed with MS 20 years ago who don't have children now because that's what they were told. And they were the same women who were told not to exercise because it would make their MS worse. So absolutely, you can still have a healthy pregnancy and absolutely a healthy baby when you have multiple sclerosis.
Thank you. And going further, is it okay to freeze eggs if you have MS?
Yeah, there's nothing wrong with your eggs when you have MS.
Okay, thank you. Next, Dr. Hunter, why is it that people are told that they cannot give blood being diagnosed with MS?
Didn't you know you're a danger to your neighbors?
Yes.
Yeah. There's no good reason. It goes back to the suspicion that people with MS must have an infection. This is an ancient concept, and they have infections just like everybody has infections. We're all full of viruses. Some of them are in our genes. But there's no real reason why they can't. But when the Red Cross makes a rule, everybody has to follow it. So you can bank blood for yourself or a family member, if you need to. You can get anything that you need, but it depends. Sometimes it's based on medications. Sometimes it's based on risk. Some things just don't make any sense and people make it up, and that's one of it. Myths about MS, there are doctors who are scared. Your biggest danger in having MS in the healthcare system is that somebody will think that, oh, you're in a wheelchair, we should not give you treatment, or you're older and you got confused a little bit because you were sick, so we should call in the hospice crew and put you down, which happens all the time with people with MS. People are told, we need to let her go because she's just, you don't want her to be like this. And it's like, she wasn't like this last week, but that's the system and you've got to be prepared.
Okay. Dr. Weigel, your feelings on stem cell replacement therapy, will it happen?
It's already happening. Stem cell therapies have been, there's plenty of research that's been published. Stem cell therapy is effective in early active inflammatory disease. And I think the challenge is that, finding a reputable way to receive stem cells versus going to stem cell clinics where they, say pay 10, whoa, our electricity just go out. Sorry. Pay, obviously not, 'cause I'm still on the internet. Pay $10,000 to $30,000 to have stem cells taken, and if you pay more money, then you can get B12 with it. If you pay more money, you can have hyperbaric oxygen. This is the challenge with stem cell treatment. So it's not currently FDA approved, and right now, from the standpoint of the National MS Society, it's still recommended to receive stem cells within the confines of a clinical trial. I do hope that one day it's FDA approved for certain.
All right. The last one is fibromyalgia and multiple sclerosis. Is it possible for them both to happen at the same time? And if so, what are the treatments? I'm going to give that to Tricia. Yes, hard one.
So neuropathic pain happens a lot in MS. You can have central pain syndromes. You can have all kinds of paresthesias, we call them, nerve type of pains. Some of those same nerve type of pains are the pains that people who have fibromyalgia describe. But fibromyalgia is a rheumatological condition. So if you have those type of pains without having that diagnosis confirmed by a rheumatologist, I would tell you that's neuropathic pain from MS. It's not fibromyalgia. I think that the rheumatologists have set a strict criteria for how they diagnose fibromyalgia. And what they use for fibromyalgia is the same treatments that we use for neuropathic pain. It's a pain syndrome. But your MS causes your pain syndrome, not fibromyalgia. But I guess you never say never in medicine. Could you have both? I guess you could.
Okay, thank you. And thank you for each of you to be up here tonight and answer these crazy long questions and et cetera. But I want to thank you for your time. Dr. Weigel, Tricia Pagnotta, Dr. Hunter, again, thank you. It was a great evening. And I want to, of course, thank our sponsors again, who we couldn't make this program happen without them. So we have Viatris, Sandoz, and Novartis, and let's all thank them. And I want to thank you all for being here.